Hi, I'm Karine Tawagi. I'm a genitourinary medical oncologist at the University of Illinois in Chicago, and I'm thrilled to be here with friend and colleague Dr. Pedro Barata. We were together in New Orleans, and now he is working at Case Western University as a genitourinary medical oncologist and has already done so many great things in this field. So we want to hear, what are some of the trials that you're excited in the non-clear cell renal cell carcinoma space?
Right, so thank you for having me, Karine. It's a pleasure to be here with you. And I think, let me just get one step back for a minute, because as you know, there's been an ongoing conversation around the designation of the non-clear cell RCC. As we know, is actually a lump of many different cancers, different biology, different behavior, different treatments perhaps, right? So, and the reason I'm highlighting that is because some of the trials that we have ongoing for non-clear cell histologies actually are not enrolling all those subtypes. So it's very different when you have a patient with papillary or translocation or chromophobe or renal medullary cancer, you know, and so or collecting duct, for instance. So a lot of the studies ongoing are actually they tend to exclude chromophobe and collecting duct and renal medullary cancer. So I'll leave them aside for now. When you asked me that question, I immediately, you know, thought of 3 or 4 trials, right? So, for instance, you know, the MET story, MET plays an important role in the biology of papillary RCC. So you have the SAMETA trial, as you know, combining an treatment with an anti-MET activity, savolitinib with durvalumab, compared to 2 other arms, right, if you will, a single therapy. Then you have different combination strategies. So you have a PD-L1 base with cabo-atezo, that's the PAP-MET2. Right. Like the story continues after the PAP-MET. It just came out with a survival update, final OS on JCO. And the PAP-MET2 is really exploring cabo-atezo versus control, control arm. And then you have 2 different IO TKIs, right? One is known to us is Axi-Pembro. Right. It's called PAX-PAM. But the other one that's perhaps the most novel of these IO TKIs is called Stellar 304. It's a combination of a novel multi-target kinase inhibitor called zanzalitinib, along with nivolumab, also randomization there, 2-to-1, to control arm sunitinib. So I think all those trials, because they're allowing, for the most part, if you take the MET-based study, SAMETA, but these trials are allowing patients beyond papillary and beyond papillary histologies. So I believe you're going to, generate data with a survival signal, because all these trials have overall survival is one of the key endpoints, right? That really, to generate the level 1 data to support what seems to be what we're doing in clinical practice. We asked that question in the online forum, and apparently 75% of us are favoring an IO TKI in clinical practice, even though we have not seen a survival signal. So I really believe those efforts are relevant to give us that signal to support, I guess, with a lot of us already considering doing that in clinical practice.
No, absolutely. And we saw some changes to the NCCN Guidelines, in the non-clear cell space. What are some of the differences that you see in the subtypes of non-clear cell? It's such a heterogeneous group.
Yeah, so you raise a fantastic point, and maybe so for your audience. So the World Health Organization redid or reclassified the tumors into large tumors, clear cell or papillary tumors. But I guess the novelty, or one of the novel points, was the new molecular defined RCC, right? Which actually have been already embedded into the many international guidelines, including ESMO Guidelines. So I invite everybody to actually check them out. And I think that's important. So that's the classification from 2022 that replaced the old classification from 2016. And so from that perspective, what we know now is mandatory to go beyond, at the pathologic level, to go beyond RCC and call it a subtype, and also report sarcomatoid and rhabdoid features. So that's really the strong recommendation. And I think this will bring us another layer, because as you know, the departments need to adapt to actually run the additional testing around the molecular characterization of tumors. So if you're going to find TFE mutated or FH, etc., right? TSC, etc. And we also know these cancers can be associated with different familial syndromes. A lot of them have to do with mutations in the tumor suppressor genes. And so that understanding is important. It's also important to consider, by the way, the germline testing for patients with non-clear cell histologies, right? And there's actually a beautiful clinical consensus paper on that by Brian Schuck and colleagues. So that's a lot to be said about it. As you said, I think the easiest ways to understand this is actually to think, we really talk about different cancers, right?
True.
And so there's a lot that goes into each one of them, and it would have different associations depending on the cancer you're referring to.
Yeah, no, absolutely. They can't all be lumped together, but unfortunately that's how we're getting enough numbers to have data for these patients.
That's right.
And we heard really exciting data about the SUNNIFORECAST trial yesterday. Could you share some of your thoughts about that trial?
Yeah, so just to give one step back, so immune checkpoint inhibitors have been explored and tested for patients with non-clear cell, papillary and beyond papillary RCC. Actually, before that trial, we have another trial, single-arm, no randomized study of AP-nivo for non-clear cell histology. Dr. Tawagi presented that data a couple of years ago, right? At that time, we saw that it was somewhat limited activity. Responses around 11%, PFS around 4 months or so, a little bit less than that. You know, and so we were not really thrilled. Dr. Rini asked a question online, what was the sense of folks for non-clear cell in regards to EP-nivo? And the majority of people are not currently employing EP-nivo in clinical practice. So we were kind of building up the expectation around SUNNIFORECAST, randomized trial, EP-nivo versus standard of care. The endpoint was overall survival rate at 12 months. And what's interesting about it is 2 or 3 things. One, the standard of care was mainly sunitinib, 87-88% of the times. The second is more than half of the patients had a papillary subtype, so it's important, right? And it's a positive endpoint, meaning there's a 10% more patients alive at 1 year compared to the standard of care. However, if you look at the curves before and after, including the median, there's no statistically significant difference. Responses were held higher, I believe it was in the high 20s, for favoring EP-nivo compared to, I guess, standard of care would be mainly sunitinib. Yeah, and it's the low 20s. Overall, I think it kind of validates the thought process that and the prior data that we see some activity with immune checkpoint inhibitors in non-clear cell. And I think what's clear to me is, but the signal is not as strong as in the clear cell histologies.
Of course.
And we do have the only prospective level 1 data that we have available is actually based on PAPMET favoring TKI. So, and I think if you put all this together, the story makes sense because folks are thinking more and more, how can we do better than a TKI monotherapy? And maybe that's the explanation behind so many of us considering a dual combination of IO-TKI in clinical practice instead of IO-IO from one end, and the other end that also supports even more, in my opinion, the role of ongoing trials with those dual or immune-based combos with IO-TKI and see if we can finally generate level 1 data with a survival advantage. So that's really what I think about when I think about SUNNIFORECAST. I think is relevant, and I think it makes sense to tell us the story that we know, at least today, and I think there's more to come.
Yeah, absolutely. Well, we're looking forward to some of your discussion on non-clear cell RCC paradigms tomorrow, and thank you for joining us in Barcelona.
Yeah, appreciate it. Thanks for having me.